Recording. Good morning, everybody. Welcome to the October Pinktober lecture series. Um, Today we have with us Dr. Sean McClellan. He completed his medical degree at Rush College in Chicago, residency in family medicine here at UIC, and followed by a clinical research fellowship at the University of California, San Francisco. He also completed with our team a training program with the University of Illinois Cancer Center that was focused on cancer prevention and primary care for cancer survivors. He's currently an assistant professor in the Department of Family and Community Medicine at UIC, where he provides general primary care and cancer prevention and survivorship care at Pilsen Health Center. His research focuses on integrating primary care and survivorship care in the United States and globally, so which he will speak with us about today. So go ahead, Sean.
Thank you. Give me 1 second as I set up the screen. Okay. Well, yeah, thank you so much, Debbie. And thank you everybody else for the opportunity to be here today.
Hey, Sean, just FYI, we're seeing your whole desktop, not just the slides.
Okay, let me try and correct that. Thank you. How about now?
It's, it's the same thing.
1 second. Let me try this now. Is that
Click on,
better?
click on start from beginning. Yeah, perfect. Looks good now, Sean. Thanks.
Okay. All right. So again, thank you, Debbie, for the introduction, and thank you all for being here today. So, I wanted to start off by briefly saying what I mean by global survivorship care. So, global survivorship care is the overlap of two different fields. Global oncology, which is focused on cancer research, cancer delivery in low resource countries or low resource healthcare systems. And then survivorship care, which is focused on sort of comprehensively meeting the needs of cancer survivors, anybody diagnosed with cancer from the time of diagnosis for the rest of their life. So survivorship care includes lots of different domains, like um, screening for or like monitoring for recurrence or new cancers, addressing long-term effects, addressing psychosocial needs, and helping to manage comorbid chronic conditions as well. Um, so then global survivorship care again is sort of just looking at how to best improve and provide survivorship care in lower resource settings globally. And then I wanted to talk a little bit about sort of my own experiences, how I got interested in this research, and how my own experiences inform the research that I do and my interests. I'm a family physician. I completed residency here at UIC. I work at Pilsen Family Health Center, and I think that's been really helpful first in just helping me understand what it means to provide comprehensive care. Um, and then also, a lot of my research is focused on understanding how to better integrate family physicians into survivorship care. And I think doing that work myself clinically helps me understand the challenges primary care providers face, what we are good at, what we struggle with, and sort of what motivates us. Um, Second, I've had experiences in Latin America that have really helped drive my research in survivorship care globally. After I finished my undergrad, I spent a year in Guatemala doing health research with a Fulbright fellowship. After that, I continued to had the opportunities to return, rotating in Mexico in primary care clinics as a medical student, as a resident. In a lot of those experiences, rotating in Mexico City as a resident, especially, really sort of sparked my interest in continuing to do work there and learn more. I was really interested in sort of how I saw that the challenges that were faced in primary care were really similar to the challenges I faced providing primary care in Chicago. So especially a lot of the sort of like bread and butter issues up here that we see, like chronic diseases, hypertension, diabetes, as well as cancer screening, cancer survivorship, were really present in Mexico City as well. So I got really interested in how I could keep learning more in both countries, and then how healthcare providers in both countries could learn from each other to improve the care we provide. Second, I had the opportunity after residency, or third, I had the opportunity after residency to complete a fellowship in clinical research and primary care research at University of California, San Francisco. And there they had a pre-established relationship with several different research institutions in Mexico focused on cancer research. And a lot of the stakeholders in Mexico really recognized the important role that primary care providers played in cancer prevention and cancer control. So it was really the perfect place for me to end up. And was able to build really strong relationships there, focused on cancer screening and early diagnosis in particular. But then later, towards the end of fellowship, became interested in cancer survivorship as well, for reasons I'll talk about a little bit more in a second. And then, sort of like the last really important pillar of my own experience that supports my research is my training and clinical work as a survivorship care provider. So, after I came back to UIC as a faculty member, um, I was able to start working with Debbie, Pam, Neha, Kristen, others from the cancer survivorship program here, and completed a year-long longitudinal training program, spending a half day a week in clinic with them, also doing some group learning, self-guided learning outside of clinic, all focused on cancer survivorship care and cancer prevention. And then since then, since September, I've been able to build on that old experience to bring that back to my clinic in Pilsen and have a half day a week of clinic there focused on primary care for cancer survivors as well as cancer prevention. So that was really a great experience to be able to not just study cancer survivorship and primary care, but also have my own practical experiences in that area to guide my research. Um, the last thing and then briefly on this slide, I just want to talk about, highlight my own research, what I'm working on now in Mexico, which we can come back to a little bit more detail at the end. But sort of the goal of my research there is to develop a program to improve care for breast cancer survivors in Mexico City. So I'm planning on working with stakeholders in Mexico, so survivors, caregivers, providers, institutional leaders, um, in interviews and workshops, building off that participation to work with them to design a program, And then, based on sort of our preliminary work there, we think that that program really needs to have a primary focus, that primary care providers in Mexico City in the healthcare system we're working with need to play a big role in survivorship care for survivorship care to be successful. So I'll come back to this towards the end of the presentation, but just wanted to um, mention it briefly now. Um, And I think the last thing I sort of want to say in terms of introduction is just to explain a little bit more why I think this research on survivorship in low and middle income countries is so important, and why primary care needs to be a part of it. So I just want to talk a little bit about an experience I had that really sort of sparked this sort of whole line of research for me. This was in 2022, and I had the opportunity to spend 6 weeks at Mexico's National Cancer Institute, one of the largest cancer hospitals nationally that provides care to patients without access to other forms of healthcare insurance. And I spent some time rotating in their outpatient breast cancer clinic there. And after a couple of days, it just really struck me the volume of cancer survivors that were seen in the clinic. One provider in a 5 hour clinic session might see 30 breast cancer patients. And of those, the majority would be cancer survivors. And of the cancer survivors, a lot of those were people who had finished sort of acute treatment like therapy, surgery, chemotherapy, radiation years ago. And we're coming back for follow-up care, often traveling at minimum across Mexico City, which is a huge city, sometimes from other states, sometimes traveling a day to be there for a follow-up appointment. And also, so again, was just really struck by that volume of providers, by that volume of patients. And the breast surgeons who ran the clinic were really excellent physicians, sort of really um, very well trained, very experienced. But even for them, it was a challenge with so many patients to sort of comprehensively address patients' needs. If they had 5 to 10 minutes to see each patient, really for survivors, a lot of the time, the most they could do would be to do a quick physical exam, do a review of systems to check for signs of recurrence, and then look at their mammography, refill endocrine therapy if they're taking endocrine therapy, and that was it. It was hard to engage much more with sort of mental health issues patients were having, long-term effects. It was a challenge. There just wasn't time for providers to sort of meet all of those needs. So seeing that those days, it really started me thinking as a primary care provider, well, what parts of this care really need to be done by breast surgeons, oncologists, and what part might a primary care doctor be able to do? And I was thinking that some of the surveillance stuff is stuff I already do as a primary provider. I do a clinical breast exam. Um, Primary care providers are sort of the most important point for early diagnosis of cancer. So we could do a lot of this work checking for recurrences. And also, sort of the rest of it, the part that's sort of being left behind a little bit here, the comprehensive part, that again is really our wheelhouse as primary care providers. So it seemed like there was a spot that primary care providers could plug into this to sort of free up space for oncologists to do other sorts of work and make sure that survivors were really having all of their needs met. So that idea stuck with me. And then over the next year or two, as I was transitioning back to UIC, I had the opportunity to talk more with research partners in Mexico, researchers here in the United States who really encouraged me to pursue that idea. Just there's been noted that there was little research so far on survivorship care in low and middle income countries generally, and especially sort of research looking at how primary care providers could be involved. So as I came back to UIC, this really became one of the main focuses of my research. Um, so I think a lot of those themes I just talked about in the last slide are sort of going to be the themes I'll explore a little further in the rest of the presentation. Sort of drawing on my what I've learned from existing research, existing data to sort of build up on those themes I just talked about. So first, we need more research on survivorship in low and middle income countries because it's a survivor population that's been growing a lot. There's just lots of cancer survivors in low and middle income countries. And this is a group with a lot of unmet needs. There's not a lot of infrastructure to support survivors in these settings. Um, there's been little research in this area to sort of guide programs for survivors. And finally, there's a need for primary care providers to be involved in survivorship care everywhere, but especially in low and middle income countries. And then finally, going to tie all these themes back to my own research that I'm working on currently. Um, so first, I do just want to say a little bit about the word low and middle income countries, which I've mentioned a few times already. So low and middle income countries are abbreviated as LMICs. Refers to the income level, the average income across a country. And sort of at the biggest level, that often gets split up as high income countries, which would be like the US, Russia, Chile are examples. And then low and middle income countries, which would sort of be everybody else. Um, and then that low and middle income country bucket will get split up further between upper middle income countries and lower and middle income countries and low income countries. So, sort of upper middle income countries are places like where I do a lot of my research, Mexico, where the GDP per person is around $12,000 a year. So, still so significantly less than lots of high income countries, but higher than many other places in the world. And then low income countries would include sort of countries with some of the lowest resource healthcare systems in the world. So places like Ethiopia, Afghanistan, North Korea. Um, so these are sort of like imperfect labels. They fail to capture a lot of the complexity of healthcare systems in different economies, but they're widely used, especially by the World Bank and elsewhere in global health. Um, so these are sort of the terms I'll be using in this presentation too. So I think this is sort of one of the most important slides in terms of understanding the growth of survivors in low and middle income countries. So this shows the orange line, just the total number of cancer survivors estimated in high income countries globally by the Global Burden of Disease Study. And then below the blue line is the total number of cancer survivors estimated in low and middle income countries. So you can see that over the last 30 years, the number of cancer survivors is growing in both regions, but it's been growing especially quickly in low and middle income countries to the point now that about half of cancer survivors globally live in low and middle income countries. Um, and that's a population that's more than doubled in the last 30 years. Um, so I think seeing this just sort of helps emphasize that this is a large population where there really is a lot of need for research to refine care. The second slide, this just sort of breaks that down in a little more detail, showing some of the nuances. So here you can see again, getting into some of those like buckets within lower and middle income countries. So you can see that while the population of survivors have grown some in lower middle income countries and maybe a little bit in low income countries, really a lot of that growth in the survivorship population is coming from upper middle income countries. Again, places like Mexico, where I do my research. There, the population of survivors has tripled in the last 30 years. So that's an area where there's especially high need for survivorship care. And then, well, I guess, so I think one question is, how do we understand what's driven this growth in upper middle income countries and then across low and middle income countries generally? And I think one thing that is part of it is just that these are large countries that have experienced a lot of growth overall. So as the population of these countries grows, it's natural that the number of cancer survivors will grow as well. So this slide sort of helps point to that a little bit, that really like the rate of cancer survivors, the number per 100,000, is still higher in high and middle income countries. But some of those large numbers that we see of the absolute number of survivors in low and middle income countries comes from just the large populations that do exist in those countries. But with that said, there has been significant growth in the prevalence rate in low and middle income countries as well, with the number of survivors per 100,000 increasing, especially in upper middle income countries. Um, Again, about doubling in the last 30 years. So there has really been an increase. It's not all just due to population growth overall, but there has really been an increase in the prevalence rate of survivors in these countries as well. And then what's driving this increase in prevalence rate? First, more people are being diagnosed with cancer. So just as an example, this shows this is a figure showing increased incidence rates in Mexico, with from 1990 to 2013, sort of the middle period of the graphs I just showed. The percentage of cancer survivors increasing especially significantly in the north of Mexico, but really across the whole country. And that's a trend that has occurred across especially upper middle income countries across the globe. And then the second important part is that not only there are more people getting cancer, but fortunately also rates of cancer survival are increasing as well. So this chart just shows some figures where you can see 5-year overall survival rates for breast cancer. They range significantly amongst low and middle income countries and even amongst upper middle income countries, with lower rates in South Africa where survival rates are closer to 50%, and then higher rates in China and Brazil, close to 80%. And you can see that even within one country, there's a lot of variation. So, for instance, nationally in Mexico, in the sort of like safety net national healthcare system, the Ministry of Health system, survivor rates have been estimated at around 70%. Whereas in another study from a different, still public healthcare system, but that's more focused on an urban population and healthcare and workers in the formal patients who work in the formal economy, so slightly higher paying jobs. You can see that there the 5-year survival rate is similar to what we see in the US overall. So I think this definitely points to the fact that there are at least like pockets or sections of low and middle income countries where survival rates are quite high, driving that increasing population of survivors, and again pointing towards the need for sort of robust programs to support survivorship care. The next thing I want to talk about is just a little bit briefly about some of the research on the unmet survivorship needs in low and middle income countries. So there really needs to be more research identifying unmet needs and characterizing those. But there have been a couple of important studies, this one by researchers from the National Cancer Institute, just pointing out that in many low and middle income, that in on the left here are low income countries and lower middle income countries, and on the right, upper middle income countries. There isn't a lot of infrastructure to support survivorship care. So most of these countries don't have a national cancer control plan that includes survivorship. Um, a high percentage of these countries, especially in upper middle income countries where we just saw that there's the greatest need, don't have sort of programs to offer supportive research to survivors. And then across these countries, there's aren't really established metrics to evaluate survivorship. And then sort of even looking at sort of global institutions, the World Health Organization has done a lot of work through the Global Breast Cancer Initiative, putting together, compiling guidelines for how to implement breast cancer care in low and middle income countries. And it's a really excellent document, hundreds of pages of long, going in detail about how to implement like treatment, screening, other parts of breast cancer care. But when it comes to survivorship, it mentions it. There are these sentences talking about how it's important. Um, but there's really much less detail about how to actually provide survivorship care, how to implement it for the patients who need it. So I think this also sort of reflects the need for more infrastructure for survivors for survivorship care, and especially survivorship care and implementation. Um, the next theme I want to touch on is just sort of stepping back from the limited infrastructure to the limited research to support infrastructure for survivors. Um, so starting off on sort of the positive side, this is an area of interest. So, as an example of sort of the interest that exists for survivorship care research in low and middle income countries, the National Cancer Institute set up an administrative supplement program in 2021 that was just focused on survivorship care in LMICs. Um, so, these are examples of some of the research that was funded based on that. So, these are administrative supplements, so lots of like sort of smaller descriptive studies, but looking at quality of life in survivors in Malawi, smoking cessation for survivors in Laos. So again, sort of addressing like lots of different issues, sort of across those domains of survivorship care in low and middle income countries. But again, sort of like smaller scale studies, overall less focused on implementation and more focused on descriptive work. And then this is one paper that just sort of highlights the again, the lack of study of implementation studies in low and middle income countries. So this was a review that found 53 different studies across the globe looking at models of cancer survivorship care, but all of those were in high income countries. None of those studies took place in low and middle income countries. So half of the cancer survivors in the world now live in low and middle income countries. But so far, we have sort of zero studies evaluating models of care in those settings. Um, And then, sort of like the last theme I want to touch on is just the importance of primary care for survivorship, especially in low and middle income countries. So, this is a figure that's from the US. It is commonly cited when talking about the importance of primary care for survivorship care here. So, it just shows how the population of cancer survivors is expected to grow over the next several decades in the US, expanding from 16.9 million to more than 26 million. And here in the US, a lot of experts have recognized that the oncology workforce won't be able to keep up with this growth in cancer survivors. So there's a need for other models, nurse-led models, primary care-led models to make sure cancer survivors continue to get comprehensive care. And then so that concern about sort of future shortages or current shortages in the oncology workforce is an even greater concern in low and middle income countries. So this just compares the number of medical oncologists per 100,000 people at by country income level. So in high income countries, it's close to one, but it's significantly less in upper middle income countries where there's a really high need for survivorship care, and even lower in lower middle income countries and low income countries. So I think that sort of those concerns about the shortage of oncology providers that we talked about in the US are even more significant in low and middle income countries, really pointing towards the needs for new models of care that incorporate primary care physicians, nurses, other sorts of providers. Another reason that primary care doctors are important in survivorship care is that we're already involved in survivorship care. So, one study found that of survivors diagnosed more than 5 years ago, this is a study from the US, more than 60% had seen an oncologist about 60% had seen an oncologist in the last 4 years, but 96% had seen a primary care provider. So we're involved in survivorship care and healthcare for almost all survivors. And for some survivors, we're already the primary source of survivorship care. Um, and then again, this study is from the US, but I think this is a pattern that applies to low and middle income countries in Mexico as well. And then on the left here, I think I just want to point out that PCPs, so a lot of our strengths and sort of providing continuity of care, comprehensive care in particular, these are really strengths that lend themselves to survivorship care. This is sort of our bread and butter, what we do every day. And it's a big part of the care that cancer survivors need. So primary care providers in the US or in Mexico or other low and middle income countries are already set up to provide this sort of care. And then there's a lot of precedent already, especially in the US, for research on primary care survivorship. So the NCI has invested a lot of money in these ongoing studies, large multi-organization studies focused on primary care survivorship. So these sorts of models are already being really rigorously investigated in the US, sort of again helping highlight that primary care survivorship is sort of being explored as the wave of the future here in the US and is something that could be applied to Mexico or other low and middle income countries as well. Um, so sort of after talking about sort of the panorama of global survivorship, um, I want to come back to sort of how this applies to my own planned research. So, I've worked with stakeholders in Mexico, researchers there, and oncologists, primary care providers to put together a proposal for a study, Caminos, to develop and test a program to improve implementation of survivorship care in Mexico City. I've submitted this as the focus of grants to the American Cancer Society and to the NIH. So this is planned research that we've started doing some preliminary work on, but still waiting for the funding to come through to get started. Um, and with Caminos, we're working with a large healthcare system in Mexico called ISSSTE. This is a public government-run healthcare system for government workers across Mexico City. So sort of like the VA in the US, but for all federal employees across Mexico. This healthcare system covers about 10% of the national population. Um, and then in Mexico City, as the country's capital, it covers an even larger part of the population. So it's a public healthcare system, sort of an integrated system like the VA, providing care for government workers. Um, and then, so we're gonna, like I mentioned, we're gonna be working with stakeholders from ISSSTE. So primary care breast cancer survivors, their caregivers, primary care providers, oncologists, um, to get their perspectives through interviews and workshops to develop a model for survivorship care. And then that'll be the first stage of our research. And then in the second stage, um, we're going to test the program Caminos. We expect this will be a program for early stage breast cancer survivors more than 5 years from completion of treatment who aren't on endocrine therapy. Um, and then we also expect that this is going to really focus on primary care providers. So we'll train primary care providers at each primary care clinic to provide breast cancer survivorship care, and then introduce other implementation strategies to support them. So some of those are listed here below, like education, tailored educational materials for patients, support groups for patients at each primary care site, treatment summaries from oncologists to primary care providers, and sort of ongoing meetings to continuously improve implementation. And then sort of the next phase of the research will be a pilot clinical trial. So this would be a small trial, just at a couple of clinics, two primary care clinics, a small number of survivors, 30 survivors each clinic. So we'd collect um, and we'd those patients would be followed for 6 months there, giving us a chance just to sort of accept or assess sort of like their overall impressions of the program's acceptability and feasibility through surveys and qualitative interviews. Um, we're also going to assess those same outcomes from implementers, so the primary care doctors, the oncologists, the institutional leaders involved with the programs, also through interviews and standardized instruments. And then another important primary outcome, we're going to measure the cost of the program. So just looking at a basic level, how much it costs to train these doctors, put this in place in two clinics, so we can make the case for scaling it up across Mexico City. And then we're also, as secondary incomes, we're going to look at some effectiveness outcomes that we could study in more detail in a later, larger trial. So receipt of recommended survivorship care, as well as patient-reported outcome measures. And then the goal of that pilot clinical trial is to inform the development of a large-scale implementation and effectiveness trial across Mexico City. Again, focus more on receipt of care, patient-reported outcome measures. Um, and then building on that research, we hope to develop a model that can be scaled up across Mexico, and then adapted to other cancer types and other low and middle income countries. Um, so, yeah, thank you for the opportunity to present to y'all today. And then please let me know if you have any questions or feel free to reach out to me. Here's my email address.
Did you want to go over that last slide, Sean? The future directions?
Oh, it duplicated information from the impact. Yeah.
Okay,
So,
great. Well, thank you, Sean, for providing that perspective on survivorship in another country. Forgive me if you kind of talked about this. What is kind of the timeline for this study? What's the goals for completion of this and for, each phase?
yeah, so I think the sort of like it's like a long timeline for collecting this preliminary data, sort of 3 or 4 years for these first steps. And I think part of that is we want to be really focused on doing this as sort of like a stakeholder involved process. So I think I didn't mention here, but one of the first steps for this will be setting up like a stakeholder committee in Mexico of survivors and others, checking in with them every few months, making sure we have the time to engage with the right stakeholders in interviews, and then for developing the program, we're planning on meeting with people every month, sort of going over different steps of developing this Caminos program. And then finally, organizing and launching the pilot clinical trial, again, sort of with guidance from stakeholders.
Mhm.
So, given that, yeah, so that's why we're making sure we want to make sure we have enough time to complete all those steps. So we're estimating sort of like 3 to 4 years to go through those preliminary steps and complete the clinical trial, the
Yeah.
pilot clinical trial.
I always learned in public health in my MPH program, it's evolution, not revolution.
Yeah, exactly.
So
Yeah.
thank you for being involved in this work, though. It's very important work that you're doing. And, I'm glad that we were able to offer some experience that helps you to
Mhm.
conceptualize and think about this in a broader sense. Does anyone else have any comments or questions for Sean? Go ahead, unmute, ask away. I'm going to start picking on people. Jean, do you have any comments on the research Sean is doing?
Sorry, I joined late, but great work, Sean. I guess my I kind of have more big picture question. I guess like with the different models, like how do you foresee like this model in Mexico can be translated to the US, or would you kind of have to like tease those apart and kind of separate them out?
Yeah, so I mean, I think this that's a great question. I think there are sort of like I think lots of different models. This is like a really active area of research. Well, I guess as you know, in the US too. So there are lots of models like this being developed in different settings across the US. And I don't think probably this model in Mexico, there are just differences in the countries and the healthcare system that just like picking it up and putting in the US without it would that would require significant adaptation and changes, I think. What I think I'm more hopeful about in terms of like is how this developing this program in Mexico could just sort of like help inform this all the ongoing research in the US. So I think a few different things is that one of the big challenges in the US is providing care for sort of like lower income, under-resourced populations in rural areas or in urban areas. And I think that's going to be a huge challenge with this sort of work in Mexico too. So, and then sort of like disparities in income and sort of some of the challenges people face are even greater in Mexico than in the US in some places. So it's sort of a chance, like if we can make this model work there and figure out how to address those challenges for people, like that sort of proves we can do it anywhere and make learn from those lessons in the US. I also think like it's interesting sort of like doing this work within like an integrated health system in Mexico. So something like East that's more along the like VA Kaiser model, those sorts of things. Like I think that's not really something that's not how most of the US healthcare system works, but I think having that reference point could help show how that's important or could inform care in the US too. And then I guess the other area that's important is just this could really help provide inform or care for Mexican American, Latino cancer survivors in the US too. So I think there's some research that shows that people's culture, um, race and ethnicity shapes how they think about survivorship care and their experiences. So sort of tailoring this program to Mexico could give us like a lot of materials, experiences, experts that could really help guide that care in the US too.
Are there any other like cultural barriers? You kind of started talking about it, but is there anything else that you foresee kind of being something that you're gonna have to compensate for in your research that you're not expecting or wouldn't see in the US?
I think there's a lot. I think there are some ideas. I mean, I think there's yeah, I mean, I think like one thing that was like obvious that's really obvious is that like almost like every single person who comes as a cancer survivor to a follow-up appointment in Mexico, not every person, but more than 50% always come with a family member. So I think again, that's just something that's like, yeah, something to account for, and also something maybe we could learn from too. I think we already know in the US how important it is to involve caregivers, but in Mexico, I think like that's going to be like, there's no alternative. You couldn't miss it, you know?
Right.
So I think that's something that could be helpful. I think there's like other things that are just more obvious there that I don't know. One thing is that I think there's sort of more fatalism about cancer still in Mexico.
Mm.
So sort of people think like if you have cancer, it's something you're likely to die from, which survival rates are a lot better there. So for lots of people, but I think that's something that's present in the US too. And I think it's a little bit easier to overlook, maybe because we're optimistic as providers about breast cancer survival.
Mhm.
But I think addressing that in Mexico will be important and could help us address it in the US. And I think just sort of one interesting consequence that I've thought about there is I think addressing fatalism in survivors can really potentially help with breast cancer prevention too. Because I think people are sometimes afraid to get mammograms done or afraid to come talk to a doctor about a mass because they think it's going to be cancer and that means they're going to die. But if there are more survivors out there saying, no, I went through treatment and I survived and
Mm,
am living, living my life, that's something that could really just sort of improve breast cancer care generally. So I think there's,
mm.
yeah, a lot to learn by doing this research in another context, another culture.
Yeah. Anyone else from our team have any comments or questions for Sean? Gonna
I have
pick
a quick
up.
question. Hi, Dr. McClellan. Thank you. This is really interesting
Yeah.
and great work. I'm just curious in terms of your role in the research and like how w will you be traveling like back and forth to Mexico, or will you be largely supporting it virtually? How do you envision that going?
Yeah, no, I think I'll be traveling back and forth a lot. I think yeah, and sort of like planning for this project, I, sort of once we actually start, I plan to sort of be in Mexico like between like 3 or 4 months a year, every year while we're getting this done. And I think I've been grateful, like our department's been like really supportive of that. And then I also think though this whole project is really possible because I have really strong research partners in Mexico too. So at sort of like the higher level, I have a mentor there who's a really experienced researcher who has been helping me with this for years. And then, but most importantly, I think, or just as importantly, within ISTE, our healthcare system partner, there's sort of two other early career researchers there, Dulce and Eduardo, who really, I think, will be putting in a lot of the legwork and working with me. We'll be sort of like a team together doing this in Mexico. So even when I'm back in the US, I'm confident there will be really strong researchers helping push it forward there.
Great, thank you. I'm always interested in like how that collaboration and like when you're working with global teams, how
Yeah,
that works. So I'm glad you're able to go and actually do work in person with them too.
yeah, for sure. No, I mean, it's a really a benefit of working in, there's been a lot of benefits of working in Mexico. I think it's easy to travel to is one. And then also, I think as an upper middle income country, there is a really well-developed research structure there. So there's a National Cancer Institute in Mexico. There's large universities. So it's been a really exciting opportunity to collaborate with experienced researchers there.
That's great to hear. I mean, we don't often think about that. I had no idea what the research infrastructure or hospital medical infrastructure was. And it's in Mexico City. As far as going out, you said to the rest of the country, some people you say come travel many miles, many hours into appointments. Um, so I mean, are you thinking of employing any type of telehealth?
Yeah, I mean, I think what we would sort of like to do ideally is in the long term. So Eastay is it's like a national healthcare system. There's clinics, hospitals in every Mexican state. So the goal I think would be to I think pilot, spend a chunk of years refining this program in Mexico City, where it's sort of like low hanging fruit, where there's more support, is more infrastructure, not low hanging fruit, but where we have a foothold.
Mhm.
But then I think where it could really have most impact if then if you could take this model and start putting it into like other East Day and other states of Mexico. So where people wouldn't have to travel as far for care, or especially in areas where there's like Chiapas, Oaxaca, where there's like
Yeah.
more challenging infrastructure. And then, yeah, I think definitely Mexico City is very concentrated, but as it expanded, I think telehealth could be a great implementation strategy too. So, yeah, I think there's a lot of um, room for learning in that area as well.
Yeah, lots of opportunities. Does anyone else have any other comments or questions? Thank you, Dr. McClellan, for telling us about this really interesting, really great research project you got going on. It does reflect in the US so much, but like also in certain ways, it's just navigating that new system and learning about it has been very interesting. So we appreciate your talk.
Yeah.
If no one
But
else has
thank you so
anything
much.
else, um, we'll be having our last lecture series, I hope, December 5th. I'm trying to figure that out. So, but till then, I hope y'all can join again and have a wonderful weekend. Thank you,
Thank you.
everyone. All right.
Thanks, Dr. McClellan.
Thank you.
Thank you.